mentioned, we had our first case on March 14th. So we just crossed the 4-month mark since the first case was reported in Rwanda. And so some of the confirmed cases that we've had are a little over 1,500. We've had more than 800 of those recovering. So they've already exited the treatment centers, and we have active cases around, it's around 700. And so unfortunately, we've had 5 deaths in the country. And the focus, I think, for us has been on testing widely, expanding the testing, right? So on one hand, there was this early action because preparedness for Rwanda started actually in January when we had the first reports that there was a virus spreading in China, and that had started to affect different parts of that area. So when we looked at the public health measures, we focused largely on testing, because that's how you know the situation, right? So I guess we can come back to it later and focus on different parts of this, but it's sort of as an overview, that's what we've been able to find.
Noella, when you say you started in January, what exactly did you do in January?
So in January, we were the focus for the surveillance, and we've remained on high alert throughout, right? We don't see it as the fight is not over, right? We've remained on high alert. In January, at points of entries, we're talking about airports and borders, we had screening. And at the time, it was thermal screening. It was multiple levels of screening, but it was symptoms-based screening. So say the international airport here in Kanombe, as you're coming down at arrival, we had temperature screening. And then we also had various sort of primary screening depending on levels of risk. So for example, if you have a plane that's coming from a highly endemic or a country that we know has a community transmission of COVID, and at the time there were several countries that were known, we would let you go through just a few questions to estimate your risks. And if we felt you were at a higher risk, we would then take you to a secondary testing and screening, which led in some areas to the test. And so that was early in January. Actually, that was towards the end of January. But then in early February, and throughout this whole process, we also insisted on public health measures. We started installing hand washing or having hand washing stations across many various settings, and enforcing physical distancing. And I want to draw a nuance here. So we try not to use social distancing, and we use physical distancing because the difference is huge, right? We're saying.
So tell us about the difference.
The difference, I was hearing about what Dr. Kaba was saying, and earlier what Russell mentioned, right? There's this idea that in our cultures, when you say social distancing, you may not be communicating what we want. What's important is reducing the risk of infection by physically being at a distance versus saying, shut down all your social connections. And this becomes important as you treat the person, because again, you treat the person as a whole, and these social contacts are important, right? So what that means is I may not be able to come and see you, but I can pick up the phone and call you. So we've been intentional about what we use when we communicate with the population. And when you speak of testing, there's issues in the supply chain, and there's a large shortage, but there's also issues when it comes to the workforce, to the materials, to the equipment. So when we approached it, we really approached it as a whole. We said, how do we expand our testing? And so in terms of the supply, we have been sort of intentional about securing the supply. And that started quite early on, meaning that we were able to develop partnerships that allowed us to be able to have access to these supplies. So that was the one, that was one of the steps of how we were able to expand the testing. But it's not just about the supplies, right? So once you have them in the country, it's also about making sure it gets to, especially those that need it the most, those that are at high risk. And so we were able to expand our network of labs, not just have one central lab, but really build satellite labs that were able to run the test. And another method, which is an innovative strategy that we did, I think people are starting to hear more about it. It's not a breakthrough, but it's being applied more and more in countries like Rwanda, is called pooled testing. So with the limited supply, you have to be intentional. So it's about combining several samples, which is the pooling side, and then testing them in a single tube, right? So you'll have batches that are negative. So then you've saved on the tests. If you find a positive sample in that batch, you then have to run it individually. But something like that can help you save thousands of tests. So we've increased our daily testing capacity by several folds. Early on, I believe in March, we had an approximate daily capacity of 300. And we've been able to expand. We're now at 3,000, 4,000, and we crossed the 5,000 threshold, I think, some point last week. But we're looking to keep increasing because expanding testing is so important. So using these strategies, whether it was securing the supplies early on, whether it's the pooled testing, because then you're able to provide more tests without using that much supply. And then also building a network of labs so it's not just centralized, but really across the country.